All right. Good luck.
Thank you. Good afternoon, everybody. We'll take another minute or so before we get started to see who else can join us. Welcome to Substance Use Disorder and Tobacco, part of the West Coast Symposium. I hope everybody is having a good day. Unfortunately, we're not at the La Quinta Resort in Palm Springs, as is normally the place where this conference is held, but we'll make do anyway. So my name is John D. Miranda, and I'm a person in long-term recovery. I've been doing workshops on the issue of substance use disorder and tobacco really for some time, and you'll hear a bit more about my kind of personal involvement in this issue. I'm an unrepentant harm reduction person in that many years ago, I remember first hearing the term harm reduction, wondering what that was because I was involved with a program and people were suggesting that because we were using terminology such as reducing the harm, that somehow we were, legalizing drugs. And I didn't get it. I didn't understand the kind of the demonization and the polarization that can sometimes go on in larger society as well as the alcohol and drug world. And I set out to kind of inform myself about this concept of harm reduction. I attended some conferences and did some reading. And the more I heard, the more it made common sense to me. And I realized over the years that I have a strong public health streak in me because minimizing harm and reducing harm is as important as abstinence and other forms of orthodoxy. I did find that when I wrote a couple of editorials asking my fellow alcohol and drug colleagues to consider the positions of harm reduction advocates, that I found myself being labeled a drug legalizer. So that was kind of an interesting experience. And I've written recently an editorial called Dirty Words, Smoker, Vapor, and Harm Reductionist. I'd like to read something from it for you. There's a saying, don't let the perfect be the enemy of good. The field's early rejection of drug harm reduction was an example. We wanted complete abstinence for our clients. Ideological purity trumped day-to-day practicality. Simply reducing use or switching to less harmful drugs was anathema. Only recently have we begun to turn the corner on the stigma associated with harm reduction strategies, such as medication-assisted treatment. In the years since, I've learned a lot about the large number of former smokers worldwide who have transitioned from cigarettes to e-cigarettes. And this is really the predicate for laying down the predicate here for much of my work right now and for the purpose of this workshop. When an individual makes this change from what we call combustible cigarettes to electronic cigarettes, they likely continue their addiction to nicotine, but reduce the pulmonary ingestion of harmful byproducts by more than 90%. It's the Royal College of Surgeons in the UK uses the 95% figure. Dr. Michael Russell, an early advocate for tobacco harm reduction, put it simply, people smoke for nicotine but die from the tar. Nevertheless, the public perception of e-cigarettes is rife with misinformation. A majority of Americans mistakenly believe e-cigarettes are as dangerous as cigarettes. And this includes about 60% of physicians. Many disapprove of and even vilify vapors as somehow vaguely undesirable. So that's really the predicate for what we're going to be talking about today. But we're going to take a little while to get there. I have no commercial disclosures to make, but I will say that the scholarship that enabled me to do the research in 2019 and continue to do more program development in 2020 is from an organization in the UK called Knowledge, Action, and Change. And that is a program of the Foundation for a Smoke-Free World, which is funded largely by Philip Morris Tobacco Company. And when I was considering applying for this scholarship, I scrutinized pretty carefully the firewall between the Philip Morris Company and the Foundation for a Smoke-Free World, and found it to be about as substantial as the firewall that exists between the Robert Wood Johnson Foundation and the pharmaceutical company Johnson & Johnson, that it was adequate. So I just put that out there for you to think about. Now, if I can get into the slide presentation. I'm having some difficulty here. There we go. Okay. So this is where it all started for me. This is Norwood Hospital. They had an alcohol and drug treatment program. And back in 1975, I found myself in there receiving treatment. And that was the beginning of my recovery from an alcohol problem, essentially an alcohol problem, a little bit of drugs, but mostly alcohol. And while I was there during that final hospitalization, the medical director of the service, himself a person in recovery, strongly warned me against quitting cigarettes for at least a minimum of 5 years into my sobriety. I think his words were, "I don't want you to even think about quitting smoking for 5 years." Granted, this was more than 40 years ago and considered the conventional wisdom then, but as I was smoking 4 packs of unfiltered cigarettes a day, it was pretty bad advice, perhaps bordering on malpractice. I eventually did quit, and even though almost 5 decades have passed, my primary care physician continues to monitor my lungs with an annual CT scan. And here we see something from the AA Grapevine, the newsletter, that kind of brings together the tobacco, alcohol, recovery message. I want to acquaint you with a study that a colleague of mine is conducting currently in San Francisco. Kevin McGurr is a faculty member at the School of Nursing at the University of California, San Francisco. And he has a major study underway, also funded by the Foundation for a Smoke-Free World. The Tobacco Harm Research Project starts with a professional staff collecting information from subjects, and they intend to study 500 subjects over 3 years who are interested in participating. They ask about their goals, their tobacco use history, and previous attempts to change. They have weekly counseling, and they provide the subjects a variety of harm reduction aids, including cessation counseling and nicotine replacement patches and lozenges, as well as e-cigarettes and snus. And we'll talk a little bit later about what snus is. And over the course of, I think, 3 months, they measure on a weekly basis changes in the tobacco use of the participants, and they collect breathalyzer information to collate with the various products that people have chosen to help them reduce or quit. There are periodic updates on their research that are available on their website. And I think it's worth looking at if you're interested in this issue. The materials are provided to subjects free of charge, and they receive a stipend to participate. And these are the products that are used: e-cigarettes, lozenges, snus down in the lower left-hand corner is pasteurized, refined tobacco that you put in your mouth. Sometimes the products similar to it are called pinch. Chantix and other smoking cessation prescribed medications, patches, and Nicorette gum. And this is their website if you want to get more detailed information about their project. It is the Tobacco Harm Reduction Research Project. So what do we know from the research? And we know that the Substance Abuse and Mental Health Services Administration reports that adults with substance use disorder account for more than 18% of all cigarettes smoked in the United States. And when you add mental health disorder to that, the number goes up to about 40%. And I think that's really worth thinking about for a minute, that 40% of all the cigarettes consumed in the United States are consumed by people with a SUD or mental health disorder diagnosis. This is way above the general population rate, which currently is, I think, about 15% of the general population smokes combustible cigarettes. I recently had the opportunity to do some focus groups. So let me go back there. Do some focus groups with persons in treatment and in recovery who were smokers. And this is part of the research that I did in 2020. And I'd like to share with you some of the findings of those focus group reports. Most of the participants reported that they had been struggling with their addiction to cigarettes for years, before, during, and after seeking treatment and recovery from alcohol and other drugs. In many cases, the use of cigarettes was and is inextricably interwoven with their other addictions, as well as their treatment and recovery. That was a kind of an unusual, unsuspected finding, that their recovery and their treatment also had very, very strong overlays of tobacco use. And some of the responses I got from people in the focus groups I'll share with you. Many participants spoke of initiating cigarette smoking during childhood, in one case as early as age 8. The overwhelming majority described families in which smoking and alcohol or drug use was commonplace, and tobacco use was inextricably linked to alcohol or other drug use. I can't emphasize this enough. I mean, I thought I knew a lot about tobacco use and smoking before these focus groups, but actually hearing firsthand from, I think it was about 35 people over 3 or 4 different groups, how important tobacco was to their addiction, how strong the bond was between the two, really helped me to understand the strength of that addiction. Some of the words that they used in describing this situation, quote, drinking and tobacco go hand in hand. The only time I smoke is a cigarette after smoking crack. Meth kind of freezes your lungs, and cigarettes are a break from the pipe. Cigarettes prolong the high, especially with weed. Cigarettes were my gateway drug. I always need a cigarette after hitting heroin. When I didn't have drugs, I used cigarettes. I only smoke when I am in my addiction. I had quit smoking, but started again when I got into rehab. Smoking tobacco brings balance to drinking and helps you pace yourself. So some of the words and comments from my focus group participants. So other things we know about from the research. For persons entering substance use disorder treatment, smoking estimates as high as 97% have been reported. In fact, if you go into most rehabilitation centers today, you'll find similar statistics. Up to 80% of smokers who enter treatment for addiction do want to quit using tobacco. And that's clear that people really do really want to change the quality of their life. We found about 15 years ago, 20 years ago maybe, a colleague and I started to do some research about the possibility of pursuing some of the tobacco control funding to do research in this area. Um, and at the time, people basically laughed at us and our proposals were thrown out because people did not understand that smoking could actually improve outcomes for substance use disorder. The conventional wisdom was very similar to what Dr. Kelly said to me when I was in treatment, that somehow quitting too early would jeopardize someone's recovery and undermine their recovery. And that's simply not the case. And not treating tobacco addiction has been shown to create a certain level of cognitive dissonance in clients who are in treatment. That, yeah, we're here to talk about your weed use or your alcohol use or your meth use. And during the break, go down into the smoke pit and have a cigarette, and we're not gonna pay attention to that. We're gonna kind of look the other way. So I think more and more emphasis has been placed on understanding this link and really doing something about it. So other things that we know, the majority of patients in treatment believe it is better to quit in those first 6 months of stopping drugs rather than waiting until later. And that was another part of the resistance to addressing this issue. Program administrators and persons who worked in the field believed that having a smoking ban or aggressively addressing tobacco addiction would somehow keep clients away, keep them out. But yet, and that sounds eerily similar to what we experienced with restaurants and especially bars when smoking ordinances began, anti-smoking ordinances began to be developed. That bartenders and restaurant owners would say, well, we're not going to have any customers. But in fact, people were able to make that transition fairly successfully. And many of these establishments have outdoor smoking areas or clients who, actually kind of appreciate the fact that these are not smoke-filled rooms anymore, but are kind of helpful, even if they're smokers themselves. So studies have increasingly found that quitting smoking improves the chances of sustained sobriety for patients treated for addictions to alcohol and other drugs. When it comes to the death, the mortality, not just the morbidity, but the mortality, persons discharged from the Mayo Clinic with diagnoses of alcohol abuse were much more likely to die from smoking-related illnesses than anything else. The most common cause of death in long-term recovering alcoholics is related to health consequences from cigarette smoking. And ironically, and perhaps not surprisingly, the two co-founders of Alcoholics Anonymous, Bill Wilson and Dr. Bob Smith, both died from smoking-related illnesses, not from alcohol or drug-related illnesses. So when I was doing my research, I was particularly attracted to a quote from one of the meta-studies that I looked at. This was a 2011 research report that appeared in Nicotine and Tobacco Research after looking at, 20 or 30 studies. In the conclusion and recommendations, the challenge was laid down. The very high smoking rates reported in addiction treatment samples warrant significant, organized, and systemic response from addiction treatment systems, from agencies that fund and regulate those systems, and from agencies concerned with tobacco control. So that's what I'm about. And in fact, the project that I've undertaken to date is now extended into a second year. And at the end of this PowerPoint, you'll hear about the tools that we hope to create and are creating for addiction treatment programs to take on this challenge in a more robust way and not kind of look the other way or adapt existing abstinence orientations, when in fact those really don't work very well for the tobacco addiction population. Okay, so I'm going to check and see if we've got any questions. No, we're good to go. So I'd like to share with you what I call the Philadelphia story. They're an interesting bunch there, and they have done some very creative and innovative work in behavioral health. And back in the early part of 2019, the Philadelphia Department of Behavioral Health and its leadership decided to initiate an aggressive policy to address the problem of nicotine addiction among those receiving substance use disorder and mental health services in their contracted facilities. The policy covers 9 detox facilities, 32 short-term rehabilitation programs, 31 long-term rehab programs, and 8 halfway houses. The Department of Behavioral Health is the principal funder of what I call the public sector tier of addiction treatment and recovery services in their community. And the commissioner then was a man named David T. Jones, who had done a lot of innovative work, especially around introducing recovery concepts into his system or years earlier. And he was a passionate proponent of the policy, believing that aggressively addressing tobacco addiction will dramatically improve all treatment outcomes. He is quoted as saying, "Smoking among Philadelphians who have a substance use or alcohol problem is at 69% and 48% respectively. 69% for the substance use and 48% for the alcohol use. By comparison, smoking among Philadelphians not using drugs or alcohol hovers at around 22%. Tobacco use kills more of our citizens than both opioid overdose and gun violence together." Pretty dramatic statistics. So the ban was put into effect. And frankly, when I first heard about it, before I had kind of undertaken my own research and my own project as a tobacco harm reduction scholar, I thought this was a good thing. This was a system that was aggressively approaching the tobacco use issue. And I did not really understand at that point in my own career development the downside to this kind of outright ban until I began to talk to some of the harm reduction activists in Philadelphia who were actively opposing this policy. And here's what they said to me, and here's what I learned, and here's how I changed my thinking about the Philadelphia approach. That in fact, this kind of blanket prohibition really is a barrier to treatment initiation for people. And if anything, we've been trying over the years to lower the threshold for treatment initiation, not increase it. It also decreases treatment retention, or I guess that's a way to phrase it, decreases treatment retention because people who are not able to continue to abstain from tobacco while they're in treatment will leave. It also disproportionately punishes marginalized populations because they have a greater proportion of smokers in their populations than the general population. The bans also violate harm reduction principles such as meeting people where they're at rather than paternalistically dictating what they should be doing with their lives. It reaffirms the idea that coercion and prohibition are effective strategies when we know intuitively and based on the evidence that coercion and prohibition are not worth the unintended consequences that come with them. And these prohibitions invariably include bans on e-cigarettes, snus, and other tobacco harm reduction products. So there's that to consider. I had an interaction with one of the proponents of the Philadelphia approach that I thought was pretty revealing. I was on a webinar, a national webinar, a few weeks back. And let me just say that almost everything that comes out of either the kind of the official leadership or governmental organizations regarding substance use disorder and tobacco, and almost everything that comes out of the national leadership and governmental agencies regarding tobacco control, the other major player here, will only promote the concept of smoking cessation. Okay, and never ever do you see in those institutions any real attention to tobacco harm reduction approaches or approaches that validate a person who wants to reduce their tobacco use. It is only the abstinence and the cessation that get into these webinars and documents and toolkits. And it reminds me again of the orthodoxy around total abstinence as opposed to drug harm reduction that we have learned for the past 20 or 30 years, um, really is not a very good policy approach. So anyway, I attended this workshop, and it was very much like this webinar now, where there was a chat function, and there was a person speaking about the Philadelphia ban, and speaking quite knowledgeably about it and quite proudly about it. And I put into the chat something to the effect that, doesn't this kind of barrier create, doesn't this kind of ban, this kind of prohibition, doesn't this create a barrier to treatment engagement? And the person, addressed it at the very end of the webinar. I think it was the last Q&A to be kind of teed up. And his response was, I thought, pretty inadequate. So I was able to track down his email address, and I sent him the following email. I viewed today's webinar and want to follow up on my question and your comments about the Philadelphia Behavioral Health Program ban on smoking as a barrier to treatment engagement. I have some questions, 2 questions really. What happens to the individual who meets the patient placement criteria from the Addiction Society of America for residential care, who presents to a residential program, but does not want to stop smoking as a condition of admission? That's question 1. Question 2, what happens to the residential client who smokes while in treatment and cannot maintain abstinence from cigarette smoking? Under the policies, my email continues, under the policies in place, can you describe in detail what specifically happens in these 2 situations? And I had also suggested he read an article that I wrote on the subject. So it took about a week for him to respond to my email. And when he did, this is the response. We believe that with thoughtful preparation, implementation, and maintenance, which includes evidence-based tobacco use disorder treatment services, pharmacotherapy, and behavioral treatment, that tobacco-free behavioral health treatment can improve important behavioral health treatment outcomes. These culture change initiatives and policies do not force individuals to quit smoking while receiving care, simply to refrain from substance use in a substance use treatment facility and to offer integrated evidence-based treatment regardless of motivational level. This is identical to the routine practice for other substances while receiving treatment. He also then went on to kind of chastise me for being a grant recipient for the Foundation for a Smoke-Free World. But if you look closely at what he says here, these policies do not force individuals to quit smoking while receiving care, when in fact they exactly do that. And that the quitting smoking is ending an addiction, which isn't easy for people. And he kind of implies that, this is a choice and that people just need to refrain from using this substance, refrain from in the treatment facilities so that they can receive treatment for their drug or alcohol problem. I thought it was a little, kind of Jesuitical to use that term. Okay, so we had these community activists who, really oppose this. Here are some of them picketing one of the treatment programs because of the van. Okay, so switching gears a little bit, what I'd like to talk about now is what are some of the problems that keep us from robustly and aggressively dealing with the smoking of combustible cigarettes among the population of substance use disorder individuals in treatment or in recovery. One is what I call the siloization of the service delivery system. We live in a world, we work in a world, and I'm sure you're all aware of this, where you receive categorical funding to do a specific task, whether it's provide services for the mentally ill, the developmentally disabled, the child protection service recipient, or the alcohol and drug addicted individual. And that categorical funding usually contains a lot of de-incentivizing of working outside of your silo. A number of years ago, and if you go on my website, you can read some of my work in trying to build bridges between the disability world, service delivery world, and activism world, and the substance use disorder treatment world. Back then, and we're talking 40 to 50 years ago, there were no bridges. These were totally compartmentalized systems. And much of my work for the National Association on Alcohol, Drugs, and Disability was about building these bridges. And it's very, very hard. You don't have to look any further than the so-called mental health substance use disorder integration that's been going on for 20 years to see that it's hard work. Even today, when we talk about co-occurring, the high levels of co-occurrence between substance use disorder and mental health diagnoses, many aspects of the administrative portions of the systems are still separate. We still have a Center for Mental Health Services within SAMHSA, the Substance Abuse and Mental Health Services Administration. And the Center for Mental Health Services looks right across at the Center for Substance Use or what they call Substance Abuse Services. And when you get down to the state levels and the county levels, more often than not, there are separate administrative divisions for mental health and substance use disorder. They are not really integrated in any substantial way. At the program level, that's not the case. At the program level, there is much more integration than at the administrative level. But that's, part of the issue is how we compartmentalize our services. Another kind of myth and barrier is that somehow sobriety trumps damage from cigarette smoking. This is exactly what Dr. John Kelly was telling me almost 50 years ago at Norwood Hospital when I was an inpatient. It's also part of the legacy of the 50s and 60s, where tobacco use, cigarette smoking was really minimized. And I remember having conversations with my mother, who was a lifelong cigarette smoker, and expressing my own incredulity that back in the 50s and 60s, she didn't, and nobody questioned the possibility that inhaling this stuff into your lungs might create some long-term damage. She said it was just not on anybody's radar screen. And I think this too, plays to the whole concept of short-term versus long-term harm, that in fact, we tend to be focused on short-term harm. And when it comes to things that might happen 20, 30, 40 years from now, they have less of a priority for us. Okay, another myth and barrier is the whole concept of recovery culture. And I think if you want to look at recovery culture, And what I mean by recovery culture is that if you take a look at some of the movies and films and books written about recovery, there are certain elements that are essentially tropes, that can come up over and over again. That, people are smoking cigarettes, they're standing around drinking coffee, they're mouthing certain phrases. And there is almost a stereotype of recovery that we've come to, kind of accept in this country. And you can see it in movies like Clean and Sober, Michael Keaton's movie, or When a Man Loves a Woman. And you can see it in late night, comedy TV too. We have this concept of recovery culture, and that is to be in recovery from an alcohol problem means you drink a lot of coffee and smoke cigarettes. Um, Another aspect of this culture and this connection really comes from, or is really evident in some more of the information that we gleaned in the focus groups that we did. So I'd like to read something else from that piece I wrote that summarized the focus group activity. We asked people, have you tried to quit or reduce? Describe your experiences quitting or reducing. Now remember, this is a population of people who are either in treatment or in early recovery or in longer term recovery. It was about 35 individuals over 3 different focus groups. Almost all participants described numerous attempts to reduce or quit cigarette use, almost always unsuccessful. And these are some of the direct quotes from the participants. 1 is too many and 100 are not enough. I had quit, but started again when I started to go to AA meetings. I can quit easily in prison, but start again when I come out. In prison, drug thinking stays with you because there are drugs around, but nobody smokes. So nicking, and that's a term that I learned from the focus group, nicking is the concept of craving nicotine, doesn't last. So nicking doesn't last. Always trying to reduce or quit. When the California prison ban started, we smoked apple seeds, banana peels, and used chewing tobacco. Yuck. Cigs are crazy expensive. Got to budget for food, housing, and smokes. Excuse me. One of the problems with these online webinars is that the speaker just has to keep talking for long periods of time, and your throat dries out. Let me take a drink. Got to budget for food, housing, and smokes. Smoking cigarettes is how my addiction shows up today. I'm at 3 to 4 packs a day, no intention to quit. Grandma smoked from 17 to 102. I would like to be not addicted to anything, but I'm really not ready. We also asked people, do you think that quitting cigarettes might endanger a person's recovery from alcohol or drugs? They reported that cigarette smoking in treatment or recovery is as important to them as cigarette use in their addiction. This was the kind of the surprising piece. Many expressed surprise and disappointment that they still smoke cigarettes, though well into their recovery from alcohol or drug use. And these are some of the quotes from the focus group members. Cigarettes allow you to maintain some control over your life. Smoking is a big part of the day in rehab. The breaks from group are smoking breaks. It's calming. Maybe we are just substituting the cigarettes for drugs. Not all houses are smoke-free. Smoking bans in rehab are counterproductive. My parole agent couldn't believe that you could get kicked out of rehab for smoking tobacco. What you learn in rehab about staying away from drugs is not transferable to quitting cigarettes. Cigarettes don't put you in jail. Maybe just deal with one substance at a time. Some rehab programs give you smokes. After the first 10 days in rehab, I was told no more cigarettes. So that's from our focus group. So a little bit about nicotine. To reiterate Michael Russell's quote that I think is really significant and drives the whole tobacco harm reduction enterprise. People smoke for the nicotine but die from the tar. So if I, or let's say you as a cigarette smoker, can make the transition from combustible cigarettes to electronic cigarettes, or to the product snus, the refined tobacco product, you reduce by 95% the junk that goes into your lungs, which is the stuff that causes the smoking-related illnesses and death. That is a pretty simple and clear public health success. And there are those in the public health community who embrace tobacco harm reduction and who work toward that goal. Unfortunately, those individuals are often demonized and kind of relegated by the larger tobacco control public health establishment that believes that only cessation, only abstinence are appropriate goals for services. So more about nicotine. Should we really be that bothered about addiction in and of itself if it doesn't come with any other substantial harms? And as a result of, well, what we're seeing is the tobacco control folks are pushing this concept that nicotine is a poison. Nicotine is a brain poison. I see this on billboards. I see it on, television advertising. And the reality is really quite different, that nicotine is certainly not a safe substance by any means, but it's a substance that people have been using, that the FDA has been approving, and we have hundreds of millions of years of experience with this substance that speaks to a relatively low risk profile. And a recent article, I just came across this today, a professor named Brad Rodu, who is a professor of medicine and tobacco harm reduction, claims that the US Centers for Disease Control and Prevention are overinflating the harms associated with nicotine in e-cigarettes. And here's a quote from the article that I read. The tobacco harm reduction expert, Ms. Dr. Rodu, said that sadly, we only have evidence of this brain harm that the CDC is referring to in mouse subjects via studies conducted in labs. The harm in brain development that federal officials talk nonstop about only happens in laboratory torture of mice. And mouse studies are well known to be of questionable value in predicting human effects, he emphasized. Rodu went on to explain that to date, there is absolutely no evidence of harm from nicotine on the brains of human subjects. There is absolutely no scientific evidence to support the claim that nicotine causes harm to human brain development. So it is astounding that federal officials traffic in this false narrative. There is no evidence of brain damage from the 34 million adult current smokers, most of whom started smoking as teenagers. Does this remind you of something? It reminds me of the targeting of cannabis 20, 30 years ago with outrageous claims for its harm potential. I remember when California was considering a citizens initiative known as Proposition 215 that was going to legalize medical cannabis, really the first of the whole cascade of medical cannabis liberalizations and legalizations that have gone on. At the time, the drug czar, General Barry McCaffrey, was quoted as saying, there is not one peer-reviewed research study that demonstrates any therapeutic value at all for cannabis At the same time, the proponents of the initiative, the Drug Policy Alliance, were waving around a list of 200 peer-reviewed studies that showed that there's some benefit from cannabis use for people with spinal cord injury or with multiple sclerosis, et cetera. So I believe that nicotine has much more in common with caffeine than it does with heroin. But unfortunately, we're seeing the nicotine be kind of demonized in a way reminiscent of what we said about cannabis during the reefer frenzy years. So anyway, in Sweden, there's an interesting experience going on, natural experiment, if you will, going on. Not too many years ago, the smoking rate in Sweden was comparable to many other European countries at the time at around 30% or high 20s. Sweden went on a big campaign to promote snus, this smoke-free tobacco product that delivers a hit of nicotine for each use of the pouch that you put in under your lip, comparable to one cigarette. And a massive number of Swedish people have transitioned from combustible cigarette use to snus, such that their combustible cigarette rate is the lowest in the world, as far as I understand it. It's below 5%. The rest of Europe hovers in the teens and low 20s, and I think the United States is at around 16%. So snus is a product that allows people to get the nicotine but not the tar, to paraphrase Dr. Russell. And it should be something that we as the public health persons embrace, not demonize. And let me also say that in Sweden, they have recently taken off from snus products the warning labels that were on it, because after so many years of large-scale use, there is absolutely no evidence of an increase in throat and mouth cancer, which was, suspected or, thought about. And similarly, snus has now been finally vetted and approved by the United States Food and Drug Administration. You could get snus before, but it didn't have the FDA kind of seal of approval that it has today. And that was just in 2019. That's at least my take on nicotine. A couple of other things to think about as we think about this issue. The cessation approaches that are the exclusive focus of national, governmental, and leadership organizations have a pretty high failure rate. Surveys carried out from 2013 to 2015 in the UK and France suggest that, on the contrary, the availability of safer alternatives to smoking is what is associated with decreased smoking prevalence and increased smoking cessation. That, just like we learned from the harm reduction years of drug harm reduction, that this was a treatment engagement strategy, and that many people who would accept a needle or a syringe, a clean needle or a syringe on the street, might eventually say, well, I think I need to get into treatment. And how some of the early drug harm reduction folks would comment that referrals to treatment were the largest request for referral services in the needle exchange programs of that era. I think we would see the same thing now, that helping people reduce their smoking and getting on a pathway where they're addressing their tobacco use is preferable to holding out a cessation only, abstinence only option that might turn people away without ever getting any help to begin on the pathway. So what are some of the tobacco harm reduction strategies that we should be thinking about? Well, cutting down. I mean, when people come in for care, they should be asked, are they interested in reducing their cigarette use? Not just, do they want to quit? Cessation programs definitely have their place. There are people that want to do that. That was certainly the way I quit smoking many, many years ago, back in 1979. I planned it for a long time. I marshaled my resources. I found the date that I wanted and the event that I wanted. And that was the end of 4-pack-a-day habit for me. But it was not necessarily the best way to go, because I was after a 4-pack-a-day habit, I was pretty addicted to nicotine. Anyway, mutual support, nicotine replacement, snuff, snooze, pinch, and dip, and e-cigarettes. And we're going to go through each of these as we move on with the workshop. So there's lots of cessation options out there. You only have to Google, tobacco in your community, and you'll be hit with the American Lung Association, various hospital workshops, webinars, services. Many of these are free. Many of them are supported by state and local governments, health departments. There's no end of those tools, and they're fine. If the person is committed to a cessation path, all of the stuff that's out there can be very helpful and useful for them to meet that goal of cessation. There's also some mutual support, or what we used to call self-help programs available. The biggest two are Nicotine Anonymous and Smart Recovery. Nicotine Anonymous is a 12-step fellowship, and it really is an abstinence, cessation-oriented program. I think online right now is the only way people can access it, just like AA and NA. It's essentially moved to an online presence. It is not a very widespread or even well-known program. I didn't learn about it until not too long ago when I was doing research in this area. Another possibility is Smart Recovery. If you're aware of Smart Recovery, you know that any addiction, any really kind of obsessive compulsive behavior, whether you want to call it addiction or not, is available, and people who want to address those issues in their lives are welcome in Smart Recovery. And my colleague Tom Horvath, who is one of the founders of Smart Recovery, says that according to the surveys they've done internally, about 2% of the Smart Recovery members / participants are there to deal with tobacco addiction. So those are options available for people. Nicotine replacement therapy. Next time you see a billboard that says nicotine is brain poison, remember that the Food and Drug Administration has for years approved nicotine replacement therapy, which means giving people small amounts of nicotine to help them either taper off their cigarette use or maintain nicotine addiction, but without combustible tobacco use. So we've had that for years. I think initially it was by prescription, and I'm not sure how long ago it became over the counter. But it's a treatment to help people stop smoking. It uses products that supply low doses of nicotine. These products do not contain many of the toxins found in smoke. And again, that figure from the Royal College of Physicians, a 95% reduction in toxins. And the goal of the NRT is to cut down on cravings for nicotine and ease the symptoms of nicotine withdrawal. It comes as a patch, a gum, a lozenge, and a nasal spray. And here's the snooze product. It is a moist powder of pasteurized smokeless tobacco originating from a variant of dry snuff in the early 18th century in Sweden. It is placed in the upper lip for extended periods, and it provides roughly the equivalent amount of nicotine that a cigarette does. And interesting, another kind of footnote about nicotine that's worth mentioning is that nicotine has some of the same properties as caffeine in that depending on the set and setting of the individual, some people use these products to relax. Some people will light up a cigarette to relax or have a cup of coffee to relax. But at the same time, some people use them for the mild stimulant function that nicotine and coffee provide. And snooze is the same. That snooze provides the improved cognitive functioning because of the nicotine. And in fact, there's some studies that are quoted in that piece that I just read to you from that show that nicotine can be not harmful, useful in some forms of dementia. There's some research to indicate that dementia can be somewhat improved. So it is not the dangerous poison that the federal government and the smoking control public health folks would have you believe. And I think that's kind of enough of that. So we're also on to e-cigarettes and vapes. This is a pretty complicated field, and it's constantly evolving. It's worth noting that the original e-cigarettes were developed not by big tobacco, but by grassroots cigarette smokers. In China was the original e-cigarette development. A man who was a cigarette smoker and a scientist began to kind of think about a safer form of smoking, and he created the first e-cigarette, I think about 15 years ago. The products have been around that long. They've constantly been evolving. And they are, they're useful and they're worth really understanding and thinking about as a possibility if you are a cigarette smoker. I'll touch on some of the hysterical press accounts of e-cigarette use and the kind of the demonization of e-cigarettes and vapes in a few minutes, but many people use these products and found them to be a useful way to either reduce or eliminate their dependence on combustible cigarettes. So, okay, now that we've kind of gone through this, and I see this as kind of the basic education part of the workshop, I want to acquaint you with what we hope to do in this coming year in terms of this particular research project that I'm involved with. We have successfully received a grant from the Foundation for a Smoke-Free World to create a toolkit for alcohol and drug treatment programs that really want to robustly address this issue. And that toolkit will include a number of pieces. And if you want information about the development of the toolkit as it occurs, and if you want information about how to get the products once they are developed, you'll find that on my website. It'll be at the end of the workshop, but it is peninsulahealthconcepts.com. The toolkit will include an assessment or audit instrument to determine the existing policies, practice, and readiness of treatment and recovery programs that seek to improve their response to client member smoking behavior. The issue I have had, both as somebody who ran treatment programs for many years and now, tries to help them improve their response to tobacco addiction, is that for the most part, treatment programs look the other way when it comes to tobacco. They don't really include in their initial assessment a serious screening tool, an assessment tool for tobacco addiction. They don't allow for the harm reduction products that would help their clients transition away from cigarettes, combustible cigarettes, to safer products. And they often accommodate people's smoking in a way that creates a certain dissonance in the treatment environment itself. When I was at one treatment program, we used to have this area on the campus facility known as the pit. And sure enough, at every break of a group or any kind of function that we were having, for most of the clients, the break became the smoking break. And they'd all be crammed down in the pit, puffing away to feed their tobacco addiction. And we would offer referral to local cessation programs. But at the time, this was, not on my radar screen. And that seemed to be kind of the acceptable approach for most treatment programs. Rarely do you find the treatment program, unless it's based in a hospital or clinical setting, that can prescribe or help to acquire nicotine replacement therapy for their clients, although that would be a good thing in many cases. So we're going to develop that instrument. I'll give you a preview of it in the next slide. We're also going to be developing 2 curricula, one for staff or professionals working in the field and one for clients, that focuses on the tobacco harm reduction strategies that we've been talking about. And then there'll be an individual substance use disorder specific smoking assessment instrument that would include stages of change and motivational components to help individuals who wish to reduce or end their combustible tobacco use. And what will be unique about all of these products is that they will be designed and developed, and the messaging and the branding will be that these are for people who have an alcohol or drug problem or are in recovery from an alcohol or drug problem. And it will speak to them using their language. That was one of the revealing pieces of the focus group, that we developed some new language that we weren't aware of by talking to consumers. Who would have thought it? Things like nicking. So that's what this toolkit will look like. These materials will be available on our website sometime later in 2021. And the organizational assessment instrument that I mentioned in the previous slide, this gives you a little preview of it. We've identified 7 levels of treatment program appropriateness or strategies or openness to addressing the tobacco issue. Level 1 is basically nothing, okay? Level 1 is the program that doesn't address it in any way. Level 2 is kind of a minimal level, maybe a smoke-free policy and a smoking pit. But all the way up to level 7 would be the treatment program that has really taken this seriously and has in place the following attributes, the following strategies, following policies. They have a formal written policy describing acceptable tobacco use practices for staff and persons served. It has tobacco use included in the welcoming statement for new clients, as well as on-site signage and resources available. It has designated tobacco use areas clearly identified, if applicable, if they want to do that. It has persons served receiving regular education about tobacco and health. And this is, this is easily incorporated into the drug curricula that I guess almost any treatment program would have some basic drug curricula that people are exposed to. Adding a significant, robust tobacco and health component is not difficult, and a lot of that is easily available from the tobacco cessation community programs that these treatment programs might already partner with. To reach a level 7 of a kind of a certification or accreditation, if you will, would also mean that the program have a tobacco harm reduction approach included in treatment goals as directed by the person served. So after the assessment, which should include significant assessment of the tobacco use of the individual, as well as the use of all other substances, that into their treatment goals is ported a tobacco harm reduction strategy for their treatment as a treatment goal. And that these goals are, of course, directed by the person served, not by the professional dictating what they should do. A level 7 program would also provide on-site tobacco harm reduction services, similar to what's provided in the research project that I mentioned at the opening part of the presentation that Kevin is undertaking here in San Francisco, Dr. Magura. The program should also provide nicotine replacement therapies or assist with access to nicotine replacement therapies or other cessation medications, if that's what the person wants. Again, the person decides, the client decides. And the program allows staff and clients to utilize non-combustible harm reduction products, such as snus, e-cigarettes, and heat-not-burn devices. And let me just comment on the heat-not-burn concept if you're not familiar with it. It's the latest iteration of kind of electronic devices that allow people to avoid all that, ingesting all that tar. Philip Morris has gone whole hog into the heat-not-burn business. They now expect to transition all of their combustible cigarette business to heat-not-burn devices, I think entirely in the next 10 to 15 years, so that they will be, according to their own, materials, out of the combustible cigarette business completely in 15 years, and be offering heat-not-burn devices, which they currently are marketing across the country in stores, a small number of stores, but I imagine they will become more widespread. And I believe their device has been approved or is under approval consideration by the FDA right now. Okay, we are coming to a close, but I'm going to back up. No, let me stay with this. It's worth noting here how the media coverage around tobacco harm reduction and around e-cigarettes has in many ways kind of mirrored some of the media coverage of our other drug hysteria, what I call hysterias, whether it was the crack baby issue of the 70s or the methamphetamine epidemic or the marijuana that was going to be the assassin of our youth. So back in 2019, you may remember that all of a sudden there were a lot of news reports about substantial lung injuries experienced by young people, mostly young people, and that there was a link to electronic cigarettes. And the initial coverage of these injuries and deaths, and there were deaths, really pointed the finger at electronic cigarettes. And invariably the news reports were electronic cigarettes are deadly, et cetera, et cetera, et cetera, kind of a worst case. This epidemic became known in the public health community as EVALI, EVALI, which stood for electronic cigarette or vaping associated lung injury. But in good public health fashion, public health, investigators began to look closely at this, epidemic and try and understand what was really going on. And at first people were at a loss. It was not clear at all what was going on. But after a significant investigation of the cases, it was determined that the culprit that was creating the injury, the lung injury and the deaths, were additives being sold in the black market on the street being created by basically black market drug dealers who were adding elements, thinning agents to cannabis pods or cannabis liquid that was being used in these e-cigarettes. And then, in fact, one of those elements was vitamin E acetate. And it was this that was this was the smoking gun. This was the ingredient that was creating the vast majority, like 90% plus, of the lung injuries and deaths. And somebody recently said that instead of calling this the E Valley epidemic, it should be the V Alley epidemic, the vitamin E related lung injury epidemic. And what's significant is that, and what's kind of tragic about this, and what repeats history about this, is that those agencies, both federal government agencies, state agencies, tobacco control NGOs, that all kind of embrace this hysteria, have done little to correct the record. And those stories that came out during 2019 still are embedded in people's psyche when it comes to talking about vaping and electronic cigarettes. And that, the factoid today that 60% of doctors believe that cigarettes are more dangerous, or e-cigarettes, excuse me, are more dangerous than combustible cigarettes is totally, hooey, but it's a persistent fact that's out there in people's minds. And the so-called adolescent vaping epidemic, certainly young people should not be smoking cigarettes. They should not be vaping e-cigarettes. They should not be doing a lot of things. But we don't have the epidemic that often, the epidemic that, the drum that gets beaten, the epidemic drum that gets beaten over and over again about protecting our youth. And by protecting our youth, meaning developing drug policies that are unrealistic, prohibitionistic, or anti-harm reduction. So that's my story. We have still 7 participants that are in the queue. I don't know if anybody has questions, but we have some time to answer questions if anybody wants to bring them up. There on the website, on the screen, you can see the website. Or if you want to email me directly or give me a call, I'm pretty accessible these days. Mostly just live in my man cave office here. Any questions? I think we have a facilitator named Dale who's there to check the chat to see if there's anything on the chat.
No, we don't have anything in the chat or the questions.
Okay. All right, then I think we're done.
Yep, I guess you explained it well enough. We don't have any questions.
I'll take that away. That sounds good. Thank you, everybody, for being part of this, and I hope to hear from you at some point. Bye-bye.
Goodbye.